All right, we'll get started. So, good morning, everyone. My name is Olivia Gray, and I'm a Sexual and Reproductive Health and Wellbeing Project Officer for the Centre of Excellence in Rural Sexual Health. And I would like to welcome you all to the Preventative Sexual and Reproductive Healthcare for Women from Refugee-like Backgrounds in Australia Sexual Wellness PD series. Today, it will be presented by Dr. Natasha Davidson, who I will introduce shortly. But before we begin, I would like to acknowledge the traditional owners of the lands and waterways across Australia from which we are all joining this morning.
Hello, how you going?
I pay
Not
my respects
bad.
to elders both past and present and emerging, and I
That's well.
extend that respect to all Aboriginal and Torres Strait Islander people here with us today. I also acknowledge the deep importance of Indigenous knowledge in the field of sexual and reproductive health. Wherever we are zooming in from, we are on Aboriginal land and sovereignty was never ceded. So before we start, just a few housekeeping notes for today's session. We kindly ask everyone to stay on mute during the presentation. Please feel free to share your questions in the chat, and at the end of the presentation, I will go through all the questions. This session is also being recorded and will be available on the Search website next week should you wish to revisit or share with your colleagues. So let's get to know today's speaker. I would like to introduce Dr. Natasha Davidson. Natasha Davidson is a research fellow at the Global and Women's Health School of Public Health and Preventative Medicine, with experience in evidence synthesis, qualitative research, survey design, collaborative research development, and translating research in policy and clinical practice. Natasha is a mixed methods and public health researcher and brings to her research and collaborations her experiences as a researcher and a registered nurse working in academic, clinical, and humanitarian roles. Natasha's PhD focused on access to preventative sexual and reproductive health care for women from refugee-like backgrounds. She has a strong interest in enhancing equitable access to primary care, health literacy, and social determinants of health. Thank you, Dr. Davidson, for presenting this morning, and over to you.
Thank you very much, Olivia. Everyone can hear me? Yep. Thank you very much, Olivia, for that very excellent introduction. I would just start by saying my background really in humanitarian work and clinical work has really informed this PhD project and really heightened my awareness and led me to undertake this work in improving access for refugee and asylum seeker women. So just by way of background, globally, the number of forcibly displaced people both within countries and across borders as a result of conflict and natural disasters has grown by over 50% in the last 12 years. At least half the total of forcibly displaced women and girls, with most coming from low-income countries, with poor health systems and living for protracted periods in refugee camps in poor conditions. A similar picture exists here in Australia, with a number of people born overseas identified in orange bars, you can see on this graph, and the proportion in the blue line, which is up to about 32% of the total of our population. About 5% of these immigrants include people with refugee backgrounds or humanitarian entrants, whose numbers have increased from around 10,000 in the early 90s to about 18,000 annually in 2024. There have also been a large number of one-off increases in recent times, partly due to global crises such as those in Syria, Ukraine, Palestine, and likely now Iran and surrounding regions. So this is going to be a continuing challenge for high-income countries offering resettlement programs. Completing this picture is the increase in the number of asylum applications in Australia over a similar period, of which about 15%, only about 15% are successful in their asylum claim. Those who are not successful in awaiting asylum applications remain in the community or in detention, still requiring healthcare and other support or settlement services. In terms of settings, historically, the majority of people with refugee and asylum seeking backgrounds settle in major cities of Sydney, Melbourne, Brisbane, and surrounding metropolitan areas. But increasingly, regional and rural settlement has been encouraged. Now, this is old data from 2016, but the trend is still increasing. As the Australian-born population decreases in regional and remote areas, overseas-born new arrivals increasingly settle in these areas, as you can see indicated by the green patches on this map. Some smaller rural and regional welcome towns have been piloted as ways to support refugees in country communities through, though these are more community-led initiatives rather than major resettlement hubs, which have implications for healthcare delivery services. Locations on the right-hand side indicate some of the key towns where new immigrants and refugees are settling. For example, there's a large population, Burmese population in the town of Nil, far western Victoria, Iran and Kurdish minorities in the Huon Valley in Tasmania, and African refugee communities in Toowoomba. Further complexity is added when we consider the pathway for people seeking asylum and the isolated exclusionary locations of Australia's immigration detention centres. Even community-based people seeking asylum are usually residing in the periphery of major centres where there are not a lot of health services specifically for asylum seekers. As well as the known health disparities regarding access to care between metropolitan and rural and regional health populations, people from refugee-like backgrounds experience additional challenges, which I hope to highlight here. Women are at particular risk of poor sexual and reproductive health outcomes compared to Australian-born women due to pre-migration conditions in their country of origin, in-transit experiences, often fleeing persecution, and on-arrival challenges related to resettlement. Many have limited education opportunities in their country of origin, increased susceptibility to gender-based violence in transit, and no choice in the decision to migrate. So why is this important? We know from recent reviews that sexual and reproductive health services such as those concerned with fertility, breast and cervical screening, and sexually transmitted diseases and other chronic conditions are underutilised by refugees and migrant communities in Australia. We also know that there are health disparities related to the prevalence of unplanned or mistimed pregnancies, sexual violence, rates of sexually transmitted diseases, and breast and cervical cancer. It is against this background that I undertook my PhD project with the aim of which was to improve our understanding of the care needs of these groups of women and the experiences of healthcare providers caring for them. So today, I'd like to concentrate on the qualitative results of interviews with women and present the cross-sectional survey of healthcare providers, and to finish with the implications and recommendations. While this qualitative research was conducted in Melbourne metropolitan LGAs or local government areas, the findings are likely to be just as relevant for regional and rural settings for the reasons I've outlined. Over a period of 2 to 3 years during the COVID pandemic, I undertook this research. Study information, so purpose, eligibility, researcher contact details, were all distributed via organisations involved in resettlement and humanitarian programs for humanitarian entrants. Recruitment was facilitated by trusted bicultural workers who directly contacted eligible women, explained the study, and coordinated interview arrangements for those who expressed an interest. Purposive sampling was used to recruit humanitarian entrants in a range of ages and lengths of time in Australia via engagement with specific community agencies. Community trust and access was strengthened through the involvement of respected community leaders, bicultural workers, and with established relationships among participants. Ethical recruitment was prioritised through the transparent processes, clear communication of voluntary participation, and the provision of written and verbal informed consent to minimise the risk of coercion. As I said, this work was undertaken through interviews conducted with Karen women from Burma, women from Syria and Iraq, and women seeking asylum from various countries. A semi-structured interview guide was developed to ask about preventative sexual and reproductive health access, use, knowledge and understanding. And we asked specific questions about access to an understanding of 4 key areas, as you can see there: contraceptive care, breast screening, cervical screening tests, and human papillomavirus vaccinations. Interviews were recorded and an interpreter was used to translate the responses where women had limited English language skills. Interviews were later transcribed. So, what did we find? There were 5 key themes across women in these population groups, and they centred on low awareness, limited perceived need for preventative care, accessing varying sources of information, including but not limited to health professionals, which is important. And in addition to low health information seeking and self-care and motivation in specific groups. Now, the following are some of the illustrative quotes used to describe these themes or used to illustrate these themes. Low awareness and knowledge stemmed mainly from pre-arrival experiences for women and limited information and access in their home countries, but some were eager to learn. For example, in relation to human papillomavirus vaccination, one woman said, "Mostly women don't know about it or have knowledge about it. Before I came to Australia, I don't know that we have to do this vaccination." Or in relation to cervical screening, "I did hear about cervical screening, I didn't do it. I don't know what it's for, this cervical screening." There was also the perception that there isn't a need for prevention, largely driven by parent or family of origin experiences. For example, a lot of people, when they were young, didn't take these vaccines. So why are we taking it now? So women don't encourage their children to have it because their parents never did when they were young. And this in relation to breast screening. Only after symptoms appeared. I have heard about it. I felt pain in my breast. When I arrived in Australia, I was lucky I went to the doctor. He found the lump. We found the lump at an early stage, so we did the surgery and had it removed. Women often sought information from various sources, but not always healthcare providers, and more importantly, not always the right information. For example, one woman stated, like a group discussion or friends, they know that gives you all the information you need. And this from a woman in Syria. "In my country, I have a lot of information. I need a lot of information about this, and I researched it everywhere in Google, the community, my doctor, and asking my nurse." Conversely, low health information seeking was also evident. Many women stating they didn't require any new information, even though the fear and hesitancy existed in some sectors of the population. For example, again, "No, there is no need for more information. I have enough information about cervical screening." Or, "I have a good idea about this breast screen," and similarly about HPV. "I don't have any questions about this vaccination." Too much information was also perceived as not benefiting women. Too much information, if you tell women that they are scared, people will think that it can cause side effects in relation to the vaccination. So they will not do it. If you tell them the side effects, they will not do it. Women also indicated that they did not prioritise screening tests. When asked why other women in their communities do not undertake cervical or breast screening, women cited competing priorities such as family and caring responsibilities, husbands' influence taking precedence over their own health-seeking behaviour. For example, sometimes women, they're not caring about their health issues. They are dependent. Their husbands don't see it as important, their wife's health. I think maybe the GPs have to educate men also, as well, I think. Men don't know about this kind of thing, cervical screening. And women themselves didn't see it as necessary. It was not important. It's not necessary to do that in their life. While these key themes outlined were also evident among women seeking asylum, other more dominant themes emerged in this population. These were more structural in nature and were clearly sectioned into individual, interpersonal, community and policy level challenges. They included psychosocial constraints, fragmented care, and the influences of spouse and extended family in their decision-making, limited community support, affordability, and immigration policy. And again, the following are some illustrative quotes supporting these themes from women seeking asylum. On the individual level, the impact of poor mental health on access to preventative sexual and reproductive care was compounded by these competing priorities, including low prioritisation of women's own health needs, of family caring responsibility, and finding employment. This quote highlights the point. I've seen some people here and back in Iran, and I think barriers to accessing screening, is linked to their low mood and their mental health. Like they are drowning in their problems, they forget themselves and they make themselves like the last priority. At the interpersonal level, women indicated that the importance of communication, trust, and cultural sensitivity in the context of accessing sexual and reproductive care. Women's relationships with their GPs and the lack of continuity of care served as a barrier. Coupled with this, providers who spoke their same language really acted as an enabler of care, as indicated here. For example, I'm happy with my GP. She is good, but then she changed and moved to another clinic. Continuity, particularly with a doctor that speaks our language, that's important. So when they change and we get a doctor that speaks only English, that's harder to have a relationship. The influence of extended family members at a community level was also identified as a significant factor affecting women's reproductive decisions. With differing expectations and pressures from family members, sometimes leading to unspoken conflicts and lack of communication between partners. In relation to the uptake of, for example, contraception. This one woman stated, there is another cultural issue which is extremely important, which is the interference of the extended family. When I got married, I didn't want to have children right away. I wanted to have a little bit of time with just my husband, having fun and not having children. My husband, on the other hand, wanted to have children straight away. Within the community, social isolation emerged as a significant barrier to accessing at least contraceptive information and services. Women noted the difficulty discussing family planning openly due to the lack of social support, networks, and cultural and religious taboos surrounding the topic. For example, in my culture, they said it is not good to use contraception. Children are a gift from God. It's not good to stop yourself from getting pregnant when you're given the chance to have children. Well, those that want to take it, contraception, it's because they have come to 2 or 3 kids now and they don't want to have any more. And life in Australia is hard with children. While back at home where I come from, I can leave my children with a friend, an auntie, without any problem. But here it's not like that. So you can kind of think, I cannot do this here. I have to stop. At a policy level, limited entitlement to Medicare was a key theme, with women regularly recounting examples of disrupted access to Medicare because of expiry or policy changes. And lastly, the challenges posed by Australia's immigration detention centre, immigration system, particularly in relation to detention, also impacted access to care. For example, one woman said, well, I didn't have Medicare for 1 year and was only given Medicare for 2 months ago. As I'm on a bridging visa, the Department of Immigration is quite strict, and Medicare used to be valid for 1 or 2 years, but it is now only valid for 6 months. And I just have to tell you that, for example, when we were in the camp, there was talk of sending us to Papua New Guinea, another detention centre. So women were trying very hard to have children. So they would take out the marina to have children, not to be sent there to PNG. So these findings formed the basis of questions for our cross-sectional survey with primary healthcare providers. Along with knowledge, attitudes and practice across all 4 content areas, contraception, screening and HPV vaccination, we asked 2 main questions in the survey. Who initiates conversations about sexual and reproductive health? And do you raise sexual and reproductive health topics for opportunistically? So this was our survey of healthcare providers. Conversations between women and healthcare providers about sexual and reproductive health can occur in both planned and opportunistic contexts. For question 1, who initiates conversations on preventative sexual and reproductive health? Now on the one side, you can see the sexual and reproductive health topics that we focused on. What I'd like to draw your attention to is the column on the right-hand side, where you can see the responses from providers who responded to, in most cases, I do option. So it was roughly between 27 and 30% of providers suggested that in most cases they initiated conversations on preventative and sexual and reproductive care. For question 2, do you bring up sexual and reproductive health opportunistically when women present for other health concerns? In this instance, providers responded yes to between 20 and 40% across the different topics. So that's 26 to 40% of women on the right-hand side again, who of health providers who brought up sexual and reproductive health opportunistically when women presented for other health concerns. These are important because we know that from previous qualitative work with women that there was limited understanding of the perceived need for these services among these groups and low health literacy regarding knowledge about these services. Providers were also asked about their perceived barriers to care for women. From a list of options, respondents were asked to select all that apply. As you can see here, barriers identified correspond with those highlighted by women themselves. Interestingly, providers attributed the top 4 barriers to care to the characteristics of women. Most reported women's cultural and religious beliefs, religious factors, and knowledge about the level as the main barriers. Fewer indicated English language skills, availability and use of interpreters, and limited time during consultations. 2 providers listed their own discomfort with the subject matter. Now, this is quite small, but I'll highlight that this table shows professional and demographic characteristics of the health providers in the survey. And just over a third, the box in the red there, were from regional and remote areas. Interestingly, we found that when we included geographic location with all other variables in the logistic regression model, Geographic location, rural versus metro, did not significantly influence the knowledge and beliefs about women's sexual and reproductive care, one way or the other. However, four other variables related to things such as direct professional experience included greater frequency with providing services to refugee women, more years practicing as a healthcare provider in Australia, and less hours worked per week, and offering a female provider positively influenced healthcare providers' knowledge and beliefs regarding women's sexual and reproductive care. So, onto the recommendations that came out of this work. I'd just like to preface these recommendations by saying that refugee-specific services such as the Asylum Seeker Resource Centre, CoHealth in Footscray, which support large numbers of newly arrived refugees and asylum seekers, are already implementing many of these approaches in practice. These recommendations are more aimed at clinics where refugee populations might not be seen in large numbers or are just new to the area, and there may be new populations to the region, or that healthcare providers are not familiar with the needs of these groups. So, in line with the findings, we identified practical and specific recommendations that focus on delivering culturally tailored sex education, sexual and reproductive education in primary care through such things as structured group discussion sessions, if it's feasible, multilingual pictorial resources, if that's feasible, and this could be in the form of monthly education workshops held at community health centres or settlement agencies, facilitated by a healthcare provider, translated brochures and videos from organisations such as the Multicultural Centre for Women's Health or Family Planning Victoria or Family Planning Association, and co-facilitated by practice nurses or bicultural workers and or interpreters if it's feasible. Strengthening language concordant care through workforce and interpreter systems, access to clinicians who speak patients' preferred language, and ensuring interpreters are used. For example, recruiting bilingual GPs and practice nurses in high demand language groups, for example, Arabic, flag patient language preferences in electronic databases for automatic interpreter bookings, and embed routine use of telephone interpreter services at bookings and consultation stages, and reception staff to pre-book interpreters for new immigrant or refugee patient appointments. We could also look at embedding preventative sexual and reproductive care into routine primary care visits if it's not already done. For example, adding cervical screening prompts to GP software such as Best Practice or Medical Director, using annual health assessments to include contraception, cervical screening, and human papillomavirus vaccination checks, and align practice with National Cervical Screening Program guidelines, such as a preventative sexual and reproductive health checklist embedded in consult templates. Develop local peer-led health literacy and self-efficacy programs. For example, a 6 to 8 week peer education program covering contraception, cervical screening, navigating Medicare, patients' rights. Sessions delivered in community venues such as religious centres and schools, which is a bit beyond the scope of health providers, build trust, improved health literacy, and supports shared lived experience and learning. And finally, using digital tools to support the reminders and self-management of sexual and reproductive care. Low barrier digital reminder systems would be one approach. SMS recall systems integrated into GP practice software, appointment and screening reminders, appointments such as hot docs for automated reminders, and trusted health information via tools such as Health Direct, automated cervical screening reminders, and SMS reminders sent to patients' preferred language where possible. And if you're interested in this work, here are a few of the relevant publications where I drew that qualitative data from. And also, this is a more detailed description of the survey data, which we published in the Australian Journal of Primary Health. And just recently, we've provided a summary article in the Monash Lens magazine, online magazine, if you're also interested in having a look at that. And finally, I'd like to just acknowledge and thank all the women and providers who participated in this project and who volunteered their time, shared their experiences so fully, especially the women and those in the community. This project could not have been undertaken without the support of the Hobsons Bay Council, specifically Amber Cassidy, and bilingual community liaison, SAY2, in the Karen community, Lena Hassan and colleagues at the Arabic Social Services. And a special thank you to Karen Elkington of the Salvation Army's Asylum Seeker Support Services. And working with refugees and asylum seekers pose many problems, even without COVID restrictions. Interviews were conducted during the height of the COVID pandemic in between lockdowns. Without their support, I would not have been able to make contact with this very hard to reach group of women and complete these studies. And then finally, a sincere thanks to my supervision team, Professor Jane Fisher and Dr. Karen Hammerberg, for being generous with their time, sharing their knowledge, and being an ongoing source of support and inspiration. I'd just like to finish, if we have time, I'd just like to finish with a short story I found on the ABC that I came upon highlighting how immigrant and refugees are contributing to regional and rural areas in Australia. Hopefully this works.
The life in the refugee camp was not easy, it was very difficult, but UNHCR did a lot of helping people to migrate, found a place where they can live, so where it is safe and stable. So they make a decision to offer us the third country, so we leave, and they brought us here to Australia. The secondary school, we learned about Australia in geography. I knew that Australia has a lot of land. When they give us information, we heard about that we have been chosen. This is the opportunity we're going to have, and maybe their life is going to change.
It makes no sense to me, having grown up in Melbourne, that people gravitate to the capital cities. It's crazy. The amount of infrastructure involved in looking after all of those people is madness. People should be encouraged to come to regional Victoria, regional Australia, and if I can help in some way to facilitate that, I'm pleased to be involved. They're fresh from Melbourne, they won't have any land, so here we are today. I've given them 1 acre of land. They've got about 1/4 of an acre of corn and beans growing, and they're talking about eggplant and cabbages and all sorts of other things, and it's just a pleasure to be involved. And they are sensational people too. That's the other thing, they're just so easy to deal with.
In terms of lifestyle, there is much difference. So here there is option you can put different option of the garden. You can do any garden you want, but in the city there is no chance you can put the garden unless you do have the backyard of where you're living.
It's an honourable thing to do. It's just a really good thing to do. It's not costing me anything. I really like the idea that it's adding cultural diversity, to the Greater Hamilton region. There's 4 families here now. If they get to their 6 or 10 families, I reckon that is just fantastic for the region.
So I'll finish there. Thank you very much. I'm happy to take questions or comments.
Seeking comprehensive presentation on preventative sexual healthcare women from refugee-like backgrounds. I haven't seen any questions pop into the chat just yet, but we do have time for some. If you would like to pop them in the chat, I can read them out, or if you're happy to unmute, that's okay as well. I did have a question though, so I might kick us off. When on that slide that said that the biggest barrier that healthcare providers perceived to be was women's cultural backgrounds, and norms, is that an assumed barrier, or has that come from women saying, I can't talk about that, that's not in my culture, that sort of thing? Does that make sense?
I think it was aimed at healthcare providers understanding the particular needs of different cultural groups. That's generally where it came from, and identifying. It's not a homogenous group, refugee and asylum seeker women. They all have particular needs, health beliefs, understanding of what health interventions mean, um, that sort of thing.
Thank you. And another question for you. How are you planning to implement this into GP clinics? Are you promoting this through the PHNs?
Well, that's a really good suggestion, and that's where we got with the Monash Lens article. The next step is to look at how we engage with PHNs, which is where we circulated the survey through initially. So part of the work now is to re-engage with them, find out if there's an appetite to participate in this next phase, and particularly in areas where there are high numbers of new arrivals settling. So yes, that would be one avenue. And then, as I said, engaging with maternal and multicultural women's health. Um, would be one avenue, and also engaging with the refugee support services that already exist to see how it's working for them. And we don't want to reinvent the wheel, so to ensure that whatever they're doing and try and relocate that to other primary healthcare providers.
Thank you. And Sarah Kell says, great presentation, thank you. Did any of the women mention or refer to menopause?
Well, actually, my colleague Karen Stanzel did a similar project, specifically looking at the experiences of called women in menopause. So I didn't specifically. It was women of reproductive age that we were targeting, so 18 to 50, and it wasn't one of the preventative fields that we looked at in our study. There was enough with those four. It had been covered elsewhere.
Thank you. And then on a similar note, did menstruation conditions come up?
Um, no, they didn't because we didn't ask about them. We didn't include it as a preventative a topic that was covered under preventative care. That's not to say it has also been well covered elsewhere with other research projects, and I can refer you to those if you like. But people were the closest we got was people talking about contraception. And of note, most of the interviews went for well over an hour, just with those four topics. It was a fairly loose, semi-structured interview, so we had to do what was feasible.
And just where can we access the full report? And then also, was there any specific mentions to termination of pregnancy in the conversations?
No, we didn't cover that at all. No, that the closest we came was looking at discussing access to contraception. And it was it was largely in primary care that we were focusing this work. Um, you know, medical abortion is something that happens in the community, but surgical abortion is definitely a tertiary level um, intervention. So we were mainly focused on primary care.
And would you just be able to reiterate where everyone can find the full version of this report, please?
Of these papers, yes,
Yeah,
I'm happy to circulate the papers. I can send them to you, Olivia, if you'd like
awesome.
to circulate them around. Um, the full report is the 100,000 word PhD project. So I don't think people want to plough through that. But I'm more than happy to send you both the Monash Lens piece and all the publications related.
Great, thank you. And then I assume this will be similar, but the next question says, how can I contact you to discuss further support for the public from the public health units working in this space?
Well, I can pop my email address in the chat now if you like. It was my last. There you go. And Olivia's got my signature on my latest email, so that you could probably circulate around as well if you like.
Yes, no worries. And then probably, I think it might be our last question for today is from our own Anne-Marie. It says, Hi Natasha, thanks for the great presentation. At SERSH, we've commenced some initial work with refugee health nurse programs funded across Victoria. We're very interested in how your findings might complement and strengthen this work. Would you be open to us reaching out to explore this further? I think your insights would be really valuable.
Oh, yes, of course. Yes, would be welcome this opportunity to collaborate. And I think it's really important in this area where there's so little um, resources that we need to work together to ensure that we get the biggest bang for our buck, or we have the strongest applications or the strongest message. So yes, I'd be more than welcome.
That's great to hear. And were there any mention of the challenges of accessing preventative healthcare for rural dwelling women? For example, some assessments may need people to travel. Is that something that puts people off?
Well, this would be an extension of this work for sure. We didn't, and it is one of the limitations. We didn't um, conduct any interviews from women from rural areas. It was just simply Melbourne metropolitan areas. I imagine it would be another level of difficulty again accessing these hard to reach groups in rural areas, but it was a limitation. Um, I don't think it would put people off. I think when women had the opportunity to talk about their experiences in their home countries and on arrival in Australia, they absolutely jumped at it. They said, no one has asked us these questions before. We haven't had the opportunity to share our stories. We really want to be heard. And this was, often it was through an interpreter or limited English. You'll notice some of those quotes were quite, they were word for word from women with limited English. So I don't think it would put people off. I think women in rural areas, if we could get access to them and engage with them, would welcome the opportunity to tell their stories.
And I think that might be our last question for today, unless anybody wanted to pop anything else in the chat. Um, but it seems like we might be finished up with the questions. But I just wanted to thank you again, Dr. Davidson, for presenting in our Sexual Wellness PD series. And thank you all for attending today. We hope that you have enjoyed the presentation. And that'll be it from all of us. Thank you so much and enjoy the rest of your days.
Thanks, Olivia. Thanks, everyone.
Thank you.